if you have a block anywhere down here, it's called a bundle branch block because we're looking at the bundles. Also, if you have impulse coming from the SA node, what's the normal rate?
60 to 100.
60 to 100. If it's coming from junctional, what is it? And if it's ventricular, okay, that's going to help you a little in telling the difference in those rhythms too. I just want to
Yeah.
go the fast way here. This is another important one as we start in the 6-second EKG, is knowing what is a sinus rhythm. So a sinus rhythm has to have these characteristics to it. All right, we okay with that? Jump out of this. Having fun playing with this? Is it your new video game? All right. To super simplify it at the beginning, these are sinus rhythms, these are atrial rhythms, these are blocks, these are junctional, and these are ventricular. Okay?
I wonder,
Nicole.
is there a way to like just test yourself on one section? Because I haven't figured that out. Okay.
There is?
Well, no. It'll give you, no, you can
I was
only
like,
go in, you can only go in to learn and do it.
Okay,
But when you get into
I
the
just
game,
want to
it's-
test myself on
it's
just the
everything.
blocks or
I'm
just.
sorry.
Okay. Oh, that's okay.
Yeah.
I
So
just
whichever
wanted
one you click on is what it'll bring up. So you, but you can't just give yourself a quiz on those
to-
5.
Okay. I just wanted to know if I was missing anything.
A lot of you guys are gonna get hung up here, right? Cause this is a little bit weird, right? So the exit block means that there is missing pieces in that strip that exactly equal the 2 beats or 3 beats before it, okay? And then on the arrest, it's just a complete missing, it doesn't correlate at all with the measurements. And then the sinus arrhythmia is mostly with children, for when you take in a deep breath, it'll speed up, and when you exhale, it'll slow down.
So can you
those are-
see that? This is breathing in, this is breathing out. So when somebody's in labor or someone's in a lot of pain or gonna pass out or something, sometimes we have a deep breath in and deep breath out. Why? We're trying to slow the heart rate. And this is just showing up, slowing up the heart rate. So all this is faster, slower, faster, slower. So don't get caught up. Some of these, I don't think they give us the best rhythms. The notch T wave doesn't mean anything, and the great big T doesn't mean anything. We're just looking at it's faster and it's slower. Let's pull up that block here so you can show that, Rod.
Okay, so if I were to measure this on a space, it should fit right here without without a lot of variation. So that's how you can tell the sinus exit block. So when we go to the.
And look at that last statement there on that.
Note that each pause is equal to a multiple of the previous P to P intervals. So that's basically what we're saying.
Nathan?
So are we taking OSCEs off this exact program, or is it gonna be?
This program, you'll play the game,
Okay.
okay? So, okay, that brings up a good point, Nate. These are just something for, you could learn and memorize this to pass, the game, but that's not gonna help you any. Learn the characteristics. Some people just try and memorize the heart rate means this. That's not teaching you anything. So, just learn the different characteristics when you're playing the game. And if you get really hung up on one rhythm, guess 3 times and it'll give you a new rhythm. So we're not looking at how many times you get wrong. It's just you understand the basic concepts there of these, okay? Now the exit arrest.
Alright, so what it says here, instead of an escape pacemaker such as the AV junction, blah, 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 where's the best part of this one?
The
It's
pause is
not equal to the multiple of P to P intervals.
So on this one, your P's won't march out. So let's go through our sinuses. Here's a sinus rhythm. Honestly, when I'm playing the game, this is the one that trips me up the most because I'm looking for something wrong. And yeah, this is the hardest one. But everything's normal there. Everything's normal here except for slow. But everything's marching out nicely. This one we're just quick. Sinus arrhythmia, you can see the differences in breathing in, breathing out, breathing in, breathing out. You don't see this a lot on adults, but you can see this on children more. And then the block where your P waves are marching out, and so with both of these, it just didn't have an impulse, so we just skipped. There was a rest or block and nothing happened.
Who has questions right now?
Yeah, but look at how long that
Between
is.
the two?
Between the blocks.
So the exit block is just has longer pauses.
Can you see, is my P wave, if we go P waves like this, and we're marching them out, then there should be one here, and then we get right back on time again. So P should have one. If I had my calipers here, one here.
If we had calipers, we'd be able to tell that it's exactly, if I put it there, it should be, and we would measure that out like that.
So it's not like that in sinus arrest.
Okay, and the
So if I
rest,
want to the arrest, if I do the P waves to P wave,
Oh, then it's off. Okay.
it's off.
No,
It's off.
not all
So
of them
this is
go.
why, you'll see the nurses on the floor when they do
Like
this,
if
they're
you're just
usually
looking at that and you
measuring
don't
things just
have
to
the
make
things,
sure
like
that
how
they
am I
can.
supposed to know that it's not exact?
Because what, 0.04 square is really, really small, and nobody can really figure that out just with your own eye. You've gotta measure that out, and so that's why those calipers are here.
okay, let's go to some atrial rhythms here. Some of the characteristics of an atrial rhythm. So this is what's called a premature atrial contraction. So your SA node fired prematurely.
Can you guys see it? So if I follow this out, P wave, QRST, P wave, QRST, P wave, QRST, P, oh, there's interrupted in my T wave. So here's my P wave. It's coming much earlier than it normally does, therefore it's premature. And the rest of it, because it still tracks in the sinus node, is gonna look very normal to what a normal P, Q, or ST would look like.
And an easy way to find these is you've got a normal rhythm going off and then all of a sudden it's too quick. And so when you've got that premature QRS, you gotta look for what caused it, and there's often a PAC in there.
So this is usually like an isolated section of it, not a continuous thing.
Yep. Just throws one here and there.
So you can see this one, what are they doing? So we got a normal, normal, not normal, 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 not normal, normal. Yeah, so it's pretty random.
So that's a premature atrial contraction. I'm gonna jump ship here now, and we're going over here. Here's a premature junctional contraction. So what does NSR mean? Normal sinus rhythm. So we're in normal sinus rhythm, and then we have a premature junctional rhythm.
So again, P wave QRST, P wave QRST, P QRST. I don't have a P wave, but I have a very normal QRS.
Yeah.
Okay, junctional. If it was wide, it would be below that junctional area. But it's narrow without a P wave, therefore it is junctional.
Anytime you have a narrow QRS that's less than 0.3, it's gone through the SA node. So it's either an atrial contraction or a junctional contraction. Anytime you have a wider than 0.3, the three boxes, 0.12, then you're looking at a ventricular, is what's sent you that impulse, and so that's a
Can
ventricular.
you say that again?
So just to distinguish between the two, the difference between a premature atrial contractions, you'll see the T wave and P wave, and this one is just one bump. together. Is that the difference between the PJC and,
And so a PJC does not have a P wave.
okay,
Okay, this is a T wave and it goes right to a QRS. There's no P wave in here. If we go back to the, PAC,
Cause this means that. Can you repeat that 0.3 less than?
so.
Like, just from the-
Linda,
So,
if you
remember
pause
the
it.
QRS has to be smaller
Linda,
than
move your cursor into
3
the-
boxes. So it's a .06.
Let's pause this.
Let's pause this.
Okay.
I will
Alright,
do that.
So this is normal, but here is this is my T wave and this is my P wave.
But if it's supposed to be.
It won't always be on top of your P wave. It could, you know, if we have a little bit long, it just came earlier.
but for the most part, you'll see the T and the P wave, they'll just be a little bit closer than normal. And then
Yes.
with the PJC, it's just
But
one
she's
little
saying
bump,
less
and
than
that's the T
0.3.
wave.
Now, if
Which
you're
is wrong?
in tachycardia, you might not
Less
even
than 3
notice that.
boxes is what she meant.
So a lot of docs will want to slow the rhythm down. They can medicate a person to slow it down so that they can see the underlying rhythm on what they're doing. When you squish everything together, you lose track of those P waves, you lose track of those T waves, and all you really see are R's, and it's really hard to tell anything. Okay? So, but if you look at, let's say that this came a little bit before this, so that it was buried completely in the T wave. This T wave would look different than the other ones. So even though you saw one bump, if this one was higher,
You know.
then you would know that there was a P wave buried in there. And it wouldn't come on top of the QRS in this instance.
The easier way, Ian, to pick up any of these prematures is you're marching off in NSR and all of a sudden you have an early QRS. So you had a premature, then you look, if you have a P wave, it's going to be a PAC. If there's no P wave, it's a PJC. Because your QRS is gonna look the same, but it came prematurely. Okay, that making sense?
Can we go back to the one that we were looking at?
The junctional?
Yeah. So there's no P wave, is what you were saying?
On the premature
On the,
one.
okay,
So if I go P wave QRS, P wave QRS, P wave QRS.
because the AV
Here it
node
is right here.
is firing instead of the SA node.
Yes, exactly.
Okay.
This one,
And you
the impulse is through the SA node, not the AV
And you were
node.
saying you can tell because the QRS is less than 3 boxes,
yeah.
not less than 0.3.
Right.
Less
So
than
let's
3
look at the
boxes.
now let's look at a PVC. So you can have a premature atrial, premature junctional, or
Here's
premature
one, here's
ventricular.
one.
Okay,
Ready?
It's coming before, there's no P wave, and this is massive, right? P wave QRS, P wave QRS, P wave QRS, T wave, no P wave, but this is really super wide.
that's the
You can't
QRS.
mistake it. And that's the pre-ventricular contraction.
But there's still a P wave?
No, there's not.
No, there's not.
There's not
Oh,
one
that's the T
on
wave. That's the T wave.
So P, QRS,
T.
T,
Gotcha.
QRS.
And then nothing else, just
So the
QRS.
impulse for this contraction came from a ventricular cell. It
Okay.
didn't go through the AV or the SA
So more
node,
like the
and so it's big and wide. But notice all the others are narrow QRSs, so they did come
Normal.
from the SA to the AV and down, but these didn't, yes.
Is the P wave indicative of the SA node, so if there's no P wave in general? Is
A
that
P
like-
wave is, you got an impulse from the SA node.
Okay, so if there's no P wave, that means that the impulse is coming from somewhere else.
Therefore, it is not stunning.
So if you have a narrow QRS, it came from the AV. If you have a wide QRS, it came from a ventricular cell, probably the bundle.
Does that mean it has a normal sinus rhythm? Cause I don't see where that's, the NSR.
Impulse is not the.
So with the patient's in NSR, but they're throwing PVCs in the middle of it.
So we would write this on our documentation, all signs for the
It just doesn't look like a normal rhythm, does it? Or am I?
Well, this part does.
Okay.
So your
So you just
underlying
ignore- You just
rhythm,
ignore everything. Okay.
there's an underlying rhythm of NSR, so and then they threw that great big PVC and went right back into NSR again.
Okay.
That makes sense? So
Yeah.
these people are the ones that just feel a great big palpitation. Feels like my heart just did a backflip in my chest or something.
Okay, so if I'm feeling a pulse on this person, and I've had my hand on their carotid or radial artery here, I'm gonna feel a pretty good pulse here. What do you think I'm gonna feel when this thing goes? These usually have less than 30% of an ejection fraction, which means less than 30%. Most of the time
So
you
it's
can't
gonna
feel
go
it
soft,
on
so
a
it'll be like-
pulse. Okay, so if you're
And then
feeling
it'll just
for
go
it,
away?
you're gonna feel these
feel it.
skipped beats.
Oh, it'll just
Beat,
feel like a regular
beat,
pulse.
beat,
Okay.
beat, beat, you're gonna feel it skip. And those might be
It's feeling
indications when
pauses
you're doing a
here.
physical assessment
Okay.
of their pulses. You guys should be doing that on your patients anyway, don't count on the monitors all the time. Get in there, if you have a skipped beat, go back and check and see if those are PVCs. For
Can you hear
college
this
age
stuff?
students, the most common,
So many people
most of you
start
guys are
making
throwing
stuff, right?
PVCs all the time, and if you're drinking power drinks, you're gonna have more of them, okay? So
Energy
Caffeine,
drinks can
real,
cause these
oh,
problems. I'm gonna die.
all of these other kind of drugs, over-the-counter cough.
Wait, so then a patient with
They'll
PVCs
set
should be
you
on
up for
strict
more
no
PVCs
caffeine?
than
Probably.
They're gonna have more, yeah. So especially when you're looking at these power drinks, if you guys are drinking those to get you through school, they are so bad on the heart. The heart's just jittering all the time.
I was asking because I just had a patient with the PVCs that I would watch quite often, and she had 4 cups of coffee sitting on her thing. So that
It could
should
be
have been.
Could be why she's having all the PVCs.
But
Did you
wouldn't
educate her? Did you tell her to stop?
I did tell her to stop after the constipation.
Now you got something to add to that teaching, right?
Yeah, that's right.
I heard a cardiologist speak one time, and he said we are going to see in 20 years totally different cardiac diseases than we are currently treating because of the energy drinks being consumed by youth right now, because the heart just jiggles. And he says what we're starting to see is a heart encapsulation around the outside of the heart, and it can't expand. And because it's just jittering so much. So be careful.
So, can you hear this? Can you hear it?
Not really. It's going to sound more like a pause. The patient's often going to feel a palpitation. But that's why I really agree with what Brother Sanders said. Get your wrist. Most nurses, they say that they took the pulse off the sat monitor. And that might or might not be accurate, but it sure, you now don't know the strength, and if it's regular, you don't know anything about it if you don't touch that pulse. So.
One of the emergency rhythms is called pulseless electrical activity, which means that the heart could be in any one of these rhythms, but there is no heart activity. It's pulseless. The person's dead, but if you hook them up to a monitor, you would see a rhythm, okay? So if you're counting on that and your patient's in PEA, you're gonna overlook some really important stuff.
Garrett?
So, did junctional rhythms mean that they originate from the AV node then, or?
Or right around there, that sounds right. Okay, let's go back again. We are going back to atrial rhythms. So we have our PAC. Now we have supraventricular tachycardia. This is actually one you will see fairly often. These are ones that extremely high heart rate. They will go in and they can shock them or give them medication to try and get them back into a normal sinus rhythm. But very, very fast. Rate 170 to 230.
So the book or the reference here says most of these things that are over 150 are going to be the SVTs. Okay, if it comes and goes back and forth, disappears, go back to the normal sinus or baseline rhythm, and then comes back again, we call that paroxysmal. Okay, paroxysmal is the fancy term for just random, comes and goes all the time. And it might be paroxysmal supraventricular tachycardia. So if you see that in the book or a text question, it's the same rhythm, only this one is sustained, the other one will go away. Okay? So the treatments to this are trying to stimulate the vagus nerve. The vagus nerve will make our heart rate go slow. So holding your breath and bearing down and putting a lot of pressure in your chest, that will sometimes be able to do it. The ice water bath, if you watch Nacho Libre with the baptism scene, that will also make your heart rate go lower, okay? And they'll try that. As long as your patient is stable, meaning that they have a decent blood pressure and ventilating well enough, cardiac output is still okay, then we're not going to mess around with medications. but the minute they become unstable, can you imagine me at 180, even if I stepped off a treadmill, would hurt me with that one. So imagine a 70-year-old woman with 180 heart rate. They don't feel well, okay? And their blood pressure is probably not gonna be that great. There's just no time for the ventricles to fill. And so everything is getting just less. And so there's a medication that will be the same as going to the power breaker of your house and shutting the power off, waiting about 6 to 8 seconds and then kicking it back on again. You guys know what that medication is called?
Mhm.
Adenosine. So adenosine will stop the heart. If you push it, you have to push it with 20 cc's of normal saline, get it into the body fast because it has about an equal half-life. Okay, so it'll last maybe 8 seconds at the most. Make sure you explain this to your patient because they're going fast and now they're not going fast. And most of them stay conscious.
I'm gonna
through
kill you
this,
for a
but
minute.
they'll give you this, because basically we put them in the asystole and then hopefully the heart comes back to it.
Hopefully the heart returns. So this is literally 6 to 8 second half-life. So push it with 20 to follow it because you want to get it to the heart really quick. It hits the heart and then it's gone.
Isn't that the one that you have to have a doctor in there with
Yes.
you?
Oh,
with
yeah,
crash
yeah,
cart?
you're not doing
Everything.
that. They're hooked up to, they're even put on paddles, so in case they need to, if something happens, we can shock them and get them back.
Okay, there's lots of Nicole, go ahead.
Oh, sorry, when we were talking earlier about the P wave being mixed with the T wave, is that what this is?
Yeah, it's really, you've got the two of them together, because it's just so fast. There are a lot of tachycardias, we'll show you several of them. The telltale for SVT is that you've got a narrow QRS.
So above 150 and narrow QRS comes.
Let's look now and compare that to junctional tachycardia. So again, we've got that super high heart rate. We have no P wave and a wider QRS. I don't like that this is a wider QRS
Because it's above
because
branch.
it should be a normal QRS. I think it even tells you that in there. The QRSs are usually narrow and then they get this sample. The reason this one is not is because you see that first impulse, it starts to come down. I'll slow it down here. If that first QRS came down here, it would be a normal, but it hits some kind of necrosis or something and it goes around, and so we get this bifurcation in it.
So if I've had a previous heart attack and it's wiped out this area, then the signature has to go around it to go through it. And what that would look like on an EKG is something like this, okay? And we're not gonna go over it. I used to understand it, but it's a little tricky. But if it's on this side, it might be on the other side. Okay, so they can tell what part of the branch is broken by looking at it on the EKG signature as well. But all that means, and when you have these bundle branch blocks, then that automatically throws your QRS out. Okay, because normally if it wasn't there, it would come straight down and it would then be a narrow QRS.
So with the junctional tachycardia, it doesn't usually look like that, is what you're saying?
It would usually have a narrow QRS.
So not with the.
And this one
Not the
looks
notch.
looks like it has a little P wave. It's really just the beginning of your QRS.
Yeah.
So when you're studying some of these and you're reading it, you want to know what it looks like. This is one version of it. It's fun to go to Google and put in junctional tachycardia, and now you get to see 20 different junctionals and what they all look like, and you can pick out the characteristics of that.
Is it just a little bit slower than SVT?
No, they're saying here fluctuates between 170 and 230 in the books. But again, if, say that we did adenosine and stopped the heart and then it was slow again and then it sped up again, that's when the cardiologist would look at the underlying rhythm and say, yeah, there's definitely no P waves in here. And so then that's when they would be able
The
to
SVT
define
has
it.
no P waves, and then the junctional tachycardia does have P waves.
The junctional does not have P waves.
Except
It
shows
can
that-
occasionally, but they're going to be inverted.
Right, but this one has P waves.
See, this one does not, it's flat.
Doesn't have a fever.
So that is not, those are not P waves, it's too close to the
I'm just
QRS.
questioning
It's starting
what's
the
difference
QRS.
between the two.
Between the two?
Yeah.
Okay, so go back to supraventricular tachycardia. it'll say on here too, it's the rate, it's gonna be the rate. But you
Right,
can't-
and this will always have a narrow QRS.
It looks very similar.
So
They look
supervision
very
failure
similar.
is just faster.
Rate, they could both be the same rate. So the difference is a junctional will have no P wave.
So,
Junctional
But
doesn't.
they both have a type QRS.
No,
She just said junctional won't have a P wave.
the junctional has a wider
Because
QRS.
junctional comes from the AV node,
so
SA
you're
node.
not gonna,
I know.
do your best with these. But to really get a true reading on that, you have to slow the heart rate down to get these.
Yeah, again, I'd love to give you another rhythm that looks a little bit better, because that's not a really good one, but they won't have a P wave. Okay, we all know atrial fib, right? And your atrium, so these are all impulses that are coming from various cells in the atrium. So this isn't all coming just from the SA node. And then some get through, and so then you get a QRS. Have you ever heard of atrial fibrillation with RVR?
No.
So that is atrial fib with rapid ventricular response, which
Oh.
means a whole bunch of these impulses are going through. So now we're very tachycardia.
So this
But
one is
we
not.
also have atrial fib as our underlying.
This one's not
You could have
RVR?
an atrial rate of over 300
Yeah.
with AFib.
They would just
So
be
these are
like
the ones that we
QRS.
worry about getting clots, because they're just jiggling, they're not emptying, and in all that broccoli that we were talking about inside of the heart, an atrium has areas where blood can pool, and so that blood will pool, and this will never get contract and get all of that out.
This one yesterday, you were telling me that it can look flat in between, like they can use
Yeah.
it so fine.
Yeah,
So-
this is really.
So depending on where the monitors are at and things like that, you might not see all this squiggly wiggly in between that represents it. It might be just flat, okay? But you're still gonna have a narrow QRS complex. And the other thing is that none of these match. They're all different because they're firing at different rates with that. So if you see a rhythm and you don't see any of the atrial involvement, it means that it's they call it fine AFib, it's in there, it's just where it's being monitored.
One help on that is when you're on the fourth floor and you go over to the monitor, if the strip that you're looking at is yellow, they're an AFib or A-flutter.
Oh.
If it's pink, it used to be orange, but I think it's pink now. If it's pink, it's going in and out of AFib and A-flutter and normal sinus. Or it was in AFib and now we're in normal sinus. If it goes back to AFib, it'll go back to yellow. So if it looks really fine, but it's yellow, print it out and look, the underlying's still gonna be fib or flutter.
Can we look at?
Now, I see a lot of eyes that are kinda, this is just an introduction. If you ever work cardiac, you will have hours and hours and hours of training on this. This is just an introduction so that you kinda have an idea. You don't have to be the cardiac specialist, right? So atrial flutter is the same as atrial fib, except it's cyclic. It's just going on a straight rhythm. So it always has that sawtooth pattern. So spend some time going over and looking at the monitor. We had 2 patients in perfect atrial flutter on Tuesday on the 4th floor. And it's not all that common to see, so.
Is one more dangerous than the other?
I think we treat them both pretty much the same. One more dangerous than the other.
Yeah, I think AFib is more dangerous than A-flutter, but I see more AFib more often. So the danger really lies if I'm not getting a good cardiac output with this from the atrium on it, and the blood is circulating, like Sister Laura just stated on that one,
Yeah.
that sometimes when they spontaneously convert to a normal sinus, that atrial kick then will dislodge anything that's already formed into a clot.
Okay.
We'll send it right into the ventricle, and if it's on the right side, it's gonna end up causing a pulmonary embolism. If it's on the left side that does it, it very likely could end up in the brain and cause a stroke.
This is one of the major causes of strokes. You see this. Okay, now we have a paced atrial. That means your patient was not able to maintain a normal heart rate, so I had to go put a pacemaker in. So these are pacer spikes. Usually when you look at the pacer spikes on the 4th floor, they'll be white. So they're a different color than your rhythm, so they're very easy to pick up, although they don't always show up. So this was a pacer spike, and then we had a P wave, so this stimulated the SA node to send an impulse. Then we got a P wave, we have a narrow QRS, so we know this is atrial.
So if I have a pacer box, usually it starts off on my left side, and the wire will go through, and they'll end up, and they'll embed it somewhere here in the atrium, okay? And so, it's actually looks like a corkscrew, and they just stick it right in there, the tissue grows over it, gives it a good contact, and that tells me that it's embedded in the atrium. Okay?
Yes.
Do you want this to look like that when they have a pacemaker?
Okay.
Yeah, that's it.
And
Now-
some of them are on-demand pacemakers, so you might see this occasionally, and then it drops, and then it comes back, and it's only needed when the heart and the SA node can't work. It's very different.
Now this is a very sick heart. Wasn't doing anything on its own, and so we are pacing just the ventricles. So you'll see there's no P wave, there's no coordination between the contraction of the atrium and the contraction of the ventricles. We are just giving a shock, and a ventricular cell is contracting. It's big and wide QRS, so we know it's ventricular. And that's where the
And
impulse.
if we have a pacer, sometimes there's dual pacers, so we might have a atrial paced and ventricular paced together. So if you see those two little spikes followed by a or a P wave and followed by a QRS, then they're dual paced.
Yep, that's a QRS too.
So is the little spike the QRS
Little
and then the
one?
big
No,
one?
this is
Yeah, that's the
the,
spike.
yeah, that's
Oh,
the
that's a spike.
pacer. That's
So
the
that whole
pacer.
thing is the QRS. Wow, that's rough.
So when you see those great big wide QRSs, this is ventricular, and when you see everything flat in front of it, there's no atrial going on, okay?
Becca, you have a question?
So, do the atrium in this just not contract ever, or?
Yeah, so we're okay not using it, they'd probably be on Coumadin just to make sure that nothing got caught up in the atrium as well on this one, but it's, the only thing that's working is the ventricle.
So our atrium is mostly emptying by gravity.
Okay.
Coming down, so. Okay, so those are your atrials. You've got your premature atrial contraction, your SVT, your atrial fib, your atrial flutter, and your paced atrial. Okay, we're gonna jump to our blocks now. These are the fun ones. This is a first degree AV block. A first degree block, you still have everything. There's never a missed QRS. So you still have a P, you still have a QRST. The only thing that's different is there's a big break from your P to your QRST. So you have a long PR interval. So remember, your PR intervals need to be one box. I'm looking, okay, so see how this one starts right at the beginning of the box? The QRS needs to be by here, but it's longer. So, you know, in class when we were talking about those people that have ASD where they have a hole between the two atriums, sometimes that doesn't close with prostaglandins and the meds they give. So they go in and they sew a Dacron patch in there so the blood doesn't go back and forth. If that impulse left the SA node and went and hit that Dacron patch, it's got to go all the way around it and get to the AV node. It still gets there every time, but it takes longer. Or if somebody's had an inferior MI and they have a lot of necrotic tissue at the back of the atrium, the impulse goes, hits that necrotic tissue, has to go all the way around it. It still always makes it, and we always have a narrow QRS.
So with just that PR interval on a
Yeah,
normal
line to line
sinus
is
rhythm,
0.2.
the PR interval should be less than 0.2 seconds?
Because that's
Mhm.
5.
That works, okay.
Just 0.0.
Just wanted
So what's the normal for a PR interval? Do you remember? We s-
Point one, two.
0.12 to 0.2. So 3 to 5 boxes is what your PR needs to be.
We saw
Little
one- We
boxes.
saw one yesterday that was 0.36. It was
Oh my gosh.
almost 2 boxes long. It was cool.
That's crazy. Did you have a question over here, Mitchell?
I got it.
Did I see a hand? Okay, so that's your first degree block. You do not have any missed QRSs, and you'll notice your Ps are marching out and your QRSs are marching out. Just a long PR interval. Okay, here's your second degree type 1. Let's get it right there.
All right, guys, on this one, because I know this gets confusing really quick, this looks like normal sinus rhythm, right? I have my P wave that's there, and then I have a QRS that is within 0.2 seconds. And then my next beat, it's obviously a little bit longer. The next beat, it's even longer, and then here, even more, and then here it completely drops.
Oh.
And then it starts all over again, longer, longest, or it drops,
Drop.
and then here we go back to normal. So on this
So like
one,
after that one, there's no
it drops.
QRS, like
It
there's supposed
drops
to be,
one
just stop.
Just drops
after an elongated, they call it Winky Bach or Mobitz type 1.
So when it drops, we still often have a P wave. P, here's your P wave, but nothing. Longer drop, but we still have a P wave, no QRS. So it's just, there was a block after that P wave, and as it's getting cyclic longer and longer, there's a drop and it totally block and it drops that QRS.
And this will consistently have like 3 P waves that get longer until the missed one?
Could be 5, could be 8, could be 2.
But if it's 6 or 8, is it always 6 or 8 in that person's heart?
Ooh, good question.
I don't know the answer to that, sorry. I wish you look that up and you teach me. I don't know if it's always the same. Okay, that's a second degree type 1. It can be called a Mobitz 1 or a Winky Bach. Now we're going to second degree type 2s.
So on the second degree type 2, we have a drop as well, and maybe multiple ones, but my PR intervals are all the same.
So you've got normal sinus, a P wave with nothing, a P wave. So this can be random. This can be every other one. If it is, it's called a 2-to-1. If it's every third that's dropped, it's a 3-to-1. If it's every fourth, it's a 4-to-1. So it's a second degree block, have a P wave, and then something blocks before you get to the AV, and we never have the QRS to follow.
So the PR intervals with the QRSs are normal, it's just that all of a sudden you have a P wave with nothing else.
So the only abnormal PRs are these two.
Okay.
Okay. This next one's another one I don't like. We saw this at clinical the other day. All they're saying is this is the exact same rhythm as the one before, but every other one. So this supposedly is a normal QRS. Again, it's bifurcated, so it should come down here, and the ST segment depression doesn't mean anything for a second degree block, so that's why I don't like this one. But again, you've got a P wave, QRS, P wave, nothing. P wave, QRS, P wave, nothing. So it's a second degree block because we have a P wave with no QRS, but it's a 2-to-1 because every other one's doing it. We had a patient, is your patient a 2-to-1 the other day? So we treat first degree blocks so they don't become second. Because a first degree block, we still have all of our QRSs, so our pulse is okay, our cardiac output's okay. But when we get to a second degree, we are missing QRSs, so cardiac output goes down. And we treat second degrees pretty aggressively because they can become a third degree, and third degrees are ominous.
So every other QRS is not there?
On a 2-to-1. So this is a third degree block.
Okay, and this one will get you if you don't pay attention to look at your P waves and are they regular, look at your QRSs and are they regular. That's part of that algorithm on that step that we gave you the very first slide, right? So if you look at this, my P waves march out exactly as they should. Now, do you guys see the difference here with how that signature looks on the rest of these? This means I have a P wave in there. And here we go with this one. So I have a rate of 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. I have almost 110 atrial beats in this strip. But how many ventricular beats do I have? Okay. So this is the equivalent of the atrial rate being at 4/4 time and the ventricular rate being at 3/4, and having different music overlapped on top of one another. Very confusing, okay? But if you were just to look at this, you might think that that was first degree heart block, right? with a PV or widened QRS, and that looks pretty normal, right? But when you start to put it all together in a strip, you need to look at this with more than a couple of beats. That's why we give you 6 seconds to look at this. Okay? This is third degree. This means that the atrial sinus node is firing differently than the AV node, and there's a complete block. Complete. That's why they call it a complete block.
So the characteristics of this one, your P waves march out. Your QRSs march out. You know, they're equal too, but they have nothing to do with each other. You can see this P wave, they just have nothing to do with them. We also know this is ventricular as is, where the impulse came from, because it's big and wide. It did not come from that P wave.
And it's also less than 40.
And so you know that that's down in that bundle because it's a rate of 40.
So to answer my question from the beginning, P waves represent the atrial rate, QRS represents ventricular rate.
Correct.
Oh, I see, okay. Yeah, so P waves, what is a P wave?
It's
Atrial contraction. What's QRS? Ventricular contraction, yeah. Okay, so that's the blocks. What questions do we have on the blocks? Did that help you with them? So just kind of easy peasy, right? Look for your PRs. Okay, now we're going to our junctional rhythms. We already talked about, this is your classic junctional rhythm. You have no P wave and you have a narrow QRS, so it's junctional. No P wave means nothing happened from the SA node.
The other telltale sign with the regular junction rhythm, it's between 40 and 60.
Yeah, but you know, remember the SA 60 to
Now it's
80
gonna get
junctional.
confusing, because now we have
So
Yeah.
there's a
accelerated.
junctional rhythm and then a premature junctional complex. What's the junction talking about?
What part of the heart the impulse is coming from? It's coming around that AV node.
Okay.
It's above the ventricles.
Okay.
It's right in here.
So junction is between SA and AV.
Actually, it's closer to the AV because if it was up by the SA, it'd be atrial. This is by where the atrium hit the ventricles, just right above the ventricles.
So no P wave.
So you guys know that if someone has a heart attack and that tissue damage happens somewhere around these nerve tracts, that's one of the most common causes that happens with it, okay? So it could be from an injury, it could be from an infection, it could be from birth, there could be a lot of reasons for it, okay? But most commonly, when people start seeing this stuff, they start digging and looking and saying, oh, they've had previous heart problems before, so this is where some of these things exist from.
So is the T wave always like bigger like that, and is it always slow? No, just like no P
Well,
wave.
yes, it's always slow.
Okay.
Okay, but the T wave
Oh,
and the
yeah.
QRS complex, that size depends on where my monitor is
Yes,
placed on the
because
body.
it's above the
Okay.
ventricles.
Yeah.
So if I put it down here in the ventricle area, I'm gonna have a great big thing. If I put it up here and monitor it, it's gonna be really small.
Yeah, that makes sense.
Yeah, so it's where you're looking at it. And yes, your question is right. It is always going to be, you know it's junctional because you have
Because,
that
yeah.
narrow QRS.
I thought about that.
Your
on the way.
QRS is normal and your rate is a junctional rate.
I was just gonna say that I've put a video on our Facebook page that helped me understand this a lot better as far as like why a wave might be inverted or why like there's no P, anyway. So if that helps, it's not the most exciting video, but it helped me understand this a lot
Why
better.
don't you send that to us and we'll put the link on the.
Yeah, that'd be great. It does help to know those because inverted and all those, and a lot of times it's just what lead we're looking at. So if something looks funny, you don't get it, go look. When you do your strips when you print your strips at the hospital, right at the very beginning, it'll tell you what lead. So if you cut off the first part, you're gonna cut off your lead. It'll say 2 or ABR or 3 or whatever. And then you know what direction you're looking at the heart. Okay, accelerated junctional. This is a junctional rhythm, but it gets a little confusing because we're not in that 40 to 60 rate. So this usually is the autonomic nervous system, fight and flight, caffeine, they saw a bear, they're excited, whatever. And so their rates increased. Absent, but you can also have inverted P waves. These these are inverted P waves. All right, we've talked about junctional tachycardia, and now your wandering pacemaker.
So remember the electrical signatures, if they look the same like these two, they're coming from the same area of the heart, presumably the SA node. Okay, this becomes the pacemaker for the atrium. But when we see that one of these looks different, see, with this one, this is coming not from here, it's coming from a different area of the atrium. And I think we have one more, and this one. So I have 1, 2, 3. That one looks like this, and then we start all over again. So I have 3 pacemakers for this rhythm. And one may be the SA node, and the other 2 are coming from other areas of the heart. Wandering pacemaker.
Will they always be from
It's
like
just
all in the
like-
atrium?
Yes.
So it's like, because like some of them are normal.
And you know that because
Some
you've
of
got a
them are
narrow
normal, and then
QRS,
there's just random ones that have
that this is a higher impulse, or a junctional impulse. Okay, that's the junctional rhythms. Now let's go to our ventricular rhythms. We talked about the PVC. This is a typical ventricular rhythm. So if the only thing that's firing is your bundle branches, and we're getting an impulse from somewhere in the ventricles, we've missed the SA node and the AV node. We know it's junctional, ventricular, because there's no P wave and it's big and wide.
And it's below 40.
Same thing, just accelerated. So again, it's getting an impulse of, that's making it faster, but no P wave, big and wide.
This one looks like the paced ventricular.
Except the pace ventricular, you've got a spike.
Yeah.
You got your pacer spike, that's the difference in the two of them. And so why is this one faster?
Because it's paced.
Because it's paced, we set the rate faster. Okay, VTAC. You need to know that one like this. Because this needs your immediate attention. What do you think the cardiac output is here?
None. None. Very
It could be. It could be.
And then our last
If
one
this
is,
is your 80-year-old grandmother, there's gonna be very little cardiac output with this. I'd be surprised if there's any.
So it's just no period. It's basically like this.
Yes.
Just like so extreme.
Of this one right here?
Basically like
So
minus.
widen QRS complex and your rate.
Your ventricular like quiver. Or just like shake.
now know that people can go in and out of VTAC. And some of them come into the hospital with syncope. Some of them don't even know it's happening. Can I tell a story on you?
Sure.
Do you all know that Brother Sanders has had open heart surgery?
Oh. I
I've
know
had
about
3
the
heart
heart.
attacks in 3 years.
Oh, good.
It's 1 a year, so thankful for that.
We're going for
your
none
prayer.
this year.
There's, yeah, the likelihood of another one is significantly high.
Not-
He's just so chill about it. That's why.
So he had a heart attack 2 years ago and had a cabbage and was up on the 4th floor. Was it 16? And was up on the 4th floor, and all of a sudden all the nurses come running in, and he was in VTAC, and
He's just
I wake
chilling.
up to a whole room full of people. Are you okay? I'm like, yeah. And she had the strip there. She said, this is what you did, and this is what I saw. I'm like, oh.
one of like 15 of them, you know?
But I slept through it all. I didn't feel it.
So that story will help you with a lot of different test questions. When they ask, what do you do? The answer is you assess your patient. You can see all kinds of rhythms. You can see a PEA where it looks like an NSR and your patient's dead. They have no pulse. We've got to start.
All right. So back to the PVCs on 30% cardiac output. at that. If I were to try to feel a pulse with somebody with this, what do you think my chances are? Probably not. There's not enough cardiac output for it. So in this case, if I saw this rhythm, and hey, are you okay? Are you okay? And there's no response, and there's somebody else with that, we're probably in this. And the next thing we need to do is shock them out of it. Okay, so this is where the crash cards come in handy. Put the pads on, and we send electricity through that heart to reset it, so that hopefully it'll go back to normal sinus rhythm again. For those that get out of a cabbage, when they came into the room with me, I had 2 wires sticking out of my chest, just down below my xiphoid process. And one was connected to the atrium, just buried in there like a fish hook, and the other one was in the ventricle. Okay? And what they would do is you'll see a box hanging on the IV pole. It's an automatic pacemaker. And they just plug the wires in, and now they can control my heart. So from that end, they can buzz me with that little battery pack thing. And then if they need to, they can control my rate from there until I can get to the cath lab and get definitive care.
Those shock you while you're awake,
Yeah.
I think?
So when you guys see wires hanging out of somebody's body,
Yeah.
they're attached to the heart. They're buried just like a fish hook. And when they pull them out, it does make you feel like a fish.
And they do that on 4th floor, so watch for it.
This might seem like an obvious question, but you were talking about, you can't wait or whatever. You would just start compressions as you call the
Yes,
code, right?
yes. Go over the bed, start compressions, get going on. Because there's not enough of the cardiac output.
I don't understand.
Oh.
Coronary artery bypass graft. And if you see it X2, X3, X4, it means the number of bypasses that they did. I'm a 3.
What happened in his hat? No, you look like a little kid.
No, your hat makes you look like a golfer.
So they also have pacemakers that they put in now that have defibrillators in them. So the patient has a pacer all the time, but if they do this, they get shocked. And so you'll see people that come into the ER and have been shocked 3 times in the last 2 hours. It hurts. And so they come in to find out what's going on, but it keeps them alive.
A good friend of mine, so you guys know, the reason why heart attacks happen in the winter a lot, out of shape, first snow happens, I have a shovel, and this happens to females too when they're vacuuming, so I'm not trying to be sexist, but every time you squeeze your hands and you do physical activity, it raises the blood pressure. Okay, so think about shoveling, it's exertional, but I'm also squeezing my hands doing it, vacuum with this and a vacuum room or whatever. So here's a guy, a friend of mine, that had an automatic internal defibrillator, and he's up in a tree with a chainsaw. No, he's a Vietnam vet, and he thought somebody shot him. So he feels this instant pain rip through the back and out the front. He falls, he's lucky he didn't get hurt with the moving chainsaw through this stuff. Hits the ground, is on a hill, rolls down a little bit, wakes up a little bit later, gets himself to the hospital, because you can go back on a pacer and you can go back in time and see what happened. And he went into VFib while he's up in the tree doing this thing, and didn't know it, and felt the shock as it converted him to it, and then when he hit the ground and moved back, he was,
What the heck?
Sometimes just hitting the ground would be enough to put you back to the
He said
NSR.
it felt like getting shot. It was that painful.
We used to many years ago, I guess 70s and 80s, when we learned CPR, we always started with a precardial thump. So you came to the patient, boom, and hope that reset him. And we've gone away from that now. But him hitting the tree was the same as that thump.
They do that on Grey's Anatomy all the time.
Somebody would be walking.
It's my favorite. I'm like, if you actually trust people, just like,
Because the cardiac output increases that fast. And so boom, they go into VFib, they lose consciousness before they hit the ground. And then when they hit the ground, they hit with such a thud that it reorganizes the rhythm and takes them back. So if you're lucky, that can happen.
like really.
I was working in the ER one day, and they were bringing in a heart attack, and they were doing CPR on this guy. He was a flat line. They had shocked him twice, and they got nothing. And the ambulance is coming super fast, and they hit a dip in the road, and the ambulance went like that. And we're in SR now. We're doing good. It was just the bump of the ambulance reset him. So people that are in this, the reason AEDs are saving so many lives is that's what they need is the shock. And so these people that we used to do CPR until the ambulance got there, now we can grab an AED, shock them earlier and save more lives because it's all about time. And that's why so many public places have AEDs. All right, our last one is, and there's no output with this. We're just, this gets your attention every time. All right, what questions do you have? That's a quick run through, but hopefully it'll tell you some telltale things to look for and make it make sense. Yes, Rick?
So, we're all supposed to know, like, code status and everything, but then on top of that, like, does everybody always know when someone has a pacemaker as well? Like, is that just really obvious and clear?
The nurses that are caring for them do. I don't know everybody on the fourth floor that has a pacer on a given day, but you should know everybody's code status just in case you walk in a room and find
So my
something.
other question is, you said that a lot of pacemakers have like a defibrillator type system in them. So, would you ever use a defibrillator on somebody that has a pacemaker, or would that
You
be?
might, yeah,
Okay.
and especially sometimes the batteries go bad, or the wire disconnects inside, or
But that's
some
not
other.
gonna like damage.
Yeah, you don't see that very often, no, it's not gonna damage.
And a lot of the new ones can be controlled by a magnet on the outside.
Yeah.
So they can take the magnet and do different things to change on the internal pacemaker.
Sometimes they can turn them off.
So that's been pretty
Yeah.
While
cool.
we're on that, let me go over this.
Like a special
Pacemakers, first pacemakers are generally put on the left side, okay? So if you're doing an assessment, and you see like a little box under the skin, that's more likely a pacemaker. The porta caps are little bumps, usually same spots. But you'll see a scar, a line across the top, and this. If you see a line and there's no bump there, if you go to the other side, there's a bump here, this is the second one, okay? If you come here and you see a line and there's a bump, and you come over here and you see a line with no bump, then this is the third one, okay? And they generally, I don't know, they're lasting a long time now, up to 8 years or so, but generally they have to go in and replace the battery pack and do all that other
So they leave the original.
So I was talking, what's that?
So do they leave the original? No.
So I was telling my clinical group at post conference, we were talking about these defibs a little, and that's something we're starting to deal with that we haven't really dealt with in the past is